Hello, good morning, everyone. I know I'm a minute early, but I'm on here to get the presentation started on time because we have so little time. It's good to see you all here. So apparently you saw that I'm using this link, obviously. Okay, so let's get started. So this should work. Perhaps you can also get ready already for the poll everywhere. And now it's 10:15. So hello again, welcome, good morning. Today we are talking about antithrombotics. You will see that I will try to talk a little faster because of the restricted time. Yeah, as always, we have learning objectives, certain groups of drugs or drugs that we will discuss. You will see this, and the lecture is structured accordingly. And I will start with some background information on blood cells and blood clotting and what these drugs are actually needed for. And you will see that you have some of that knowledge from previous lectures. So starting with blood cells, the cell we are interested in today are mainly the platelets or thrombocytes or thrombocyta. And as you know, they are derived from the bone marrow where you have precursor cells, and from these precursor cells, the body forms red blood cells, white blood cells, and the platelets. And that's, of course, what we are interested in, the platelets, when we talk about blood clots and thrombotic diseases. So to a little reminder, what is happening in case that we get injured, perhaps cut ourselves into the finger and we have a bleeding, then the body reacts and forms a blood clot. I can see that there are 4 messages in the chat. I just have a quick look. Okay. Good. So nothing going wrong. I just wanted to check whether there's any technical problem, but it seems all right. So what is happening in the body when we have an injury and the body by itself is trying to stop a bleeding? That's important to know because, as you will see, the drugs that we are talking about today, they interfere with this process. So to understand the drug, we need to understand first what the body is doing by itself. And the first thing that is happening in the body when we have an injury of a little blood vessel here is that there is vasoconstriction. So the body excretes substances that will constrict the vessel and by that stop the bleeding. Or actually it doesn't stop the bleeding, but at least it reduces the bleeding a little bit. That's a very fast action. And this is also made use of in daily practice, specifically the dentist. When the dentist gives you an injection with an anesthetic for a small surgery, they usually also add some adrenaline to make this vasoconstriction even stronger than what the body will then do by itself. That is to reduce bleeding, but it also so that the anesthetic remains longer at the site of surgical intervention, so that it's not floated away by the bloodstream so fast. And I thought I use this for a little warm-up and a reminder of the lecture on ANS2. I hope this is working now. So we have a first question here. Which adrenergic receptor is responsible for vasoconstriction by adrenaline? And today it's working. I hope you can see this also. I can see it. I can see, yeah, vast majority is responding alpha-1. And since we do not have a lot of time, I stop it right here. You are correct. It's the alpha-1 receptor on smooth muscle cells in vessels. And if that is stimulated by adrenaline, we get vasoconstriction, so a narrowing of diameter of the blood vessels. Perfect. And now I hope I can move this forward. Perhaps this doesn't move. Maybe here. Don't really know how to get this going. Perhaps if I'm a little more patient, I can do it here. Okay, I think I need to stop presentation mode and go into presentation mode again. Sorry for this. Something I still need to figure out. Okay, so next step, how a body tries to stop bleeding by itself, is platelet aggregation. So here you have all the small thrombocytes, platelets, that aggregate together, and this is a process that we will look at more closely in the following, because we have drugs interfering here. So with platelet aggregation, you get a preliminary blood clot by aggregating platelets, and then there's a final step, or no, sorry, this is how it looks. These are non-activated platelets, and when they get activated in a way that we will look at during the next slides, they form these extensions here, and they also form certain receptors which are then able to form fibrogen links between the different platelets, and by that they aggregate together. Okay, and then the final step, that's called coagulation, and that is the process of synthesis of fibrin and of formation of the fibrin net that will then kind of tie together this preliminary clot by aggregating platelets. Yeah, so that will stabilize a blood clot, and by that blood clot formation is finalized. And we also have drugs interfering here with this process of fibrin synthesis and coagulation. That's another electron microscope is picture, a bit modified, colored, and so on. And you see the fibrin net here surrounding some actually red blood cells. They're of course also around. Okay, so let's look at the main classes of drugs that interfere with formation of blood clots. And as I said, we have drugs that interfere with platelet aggregation. They are called in English antiplatelet drugs. And this I will not try to pronounce, but at least I thought I put it in Danish so that you will recognize the term in a question. But as you see, it's basically saying the same, just using a little different terminology. So we have the antiplatelet drugs, and then on the other hand, we have the anticoagulant drugs that interfere with the formation of the fibrin net, or the synthesis of fibrin. And this is very important. So please, if you sit down and read about these antithrombotics, always keep in mind we have these two classes of drugs, and the way they act, the mechanism of action is very different. One group of drugs interacts with platelet aggregation, and the other group of drugs interacts with coagulation. And that's something really different. And I'm repeatedly quite often asked for a specific class of drugs, and either the antiplatelet drugs or the anticoagulants, so that you have to assign a certain drug to a group, one of these two groups. So be aware of this, because it's important. The use of the drugs is also slightly important, as I have on the last slide, if we get there. Okay, but really importantly, the mechanism of action is different. So just a few words on about where do we need these drugs. So as discussed now, we have drugs that interfere with the natural process of clot formation. And of course, where we need these drugs is diseases where we have pathological clot formation. And that could be, for example, clot formation in the deep veins of a leg that you can see here, the swollen leg. It's swollen because the blood flow back to the body is disturbed by a clot in the veins. It's also a bit bluish, like the bluish color of blood in veins. Another example, sorry, I have to keep this a little short. Another example, myocardial infarction, heart attack, where you have a blood clot sitting in one of the arteries that nourish the muscular tissue of the heart. And if that happens, of course, you have lack of oxygen here and the tissue dies. So antithrombotic drugs are used to dissolve the clot, or also to prevent clot formation in people with a high risk to have a myocardial infarction. And as a third example, there would be many more, but as a third since we are all, of course, always talking about COVID, yes, they're also used in COVID. So relatively early on during the pandemic, people realized that the patients with a very severe course of disease, only those, they have a higher risk of clotting because they have an inflammation of the endothelial cells of their blood vessels. So many of these people with severe causes of COVID-19, especially in the beginning, they died from a heart attack or stroke, but now they are treated with antithrombotics, and that made the situation much better. All right, so let's start with the antiplatelet drugs. These are the drugs, as I said, that interfere with platelet aggregation. And to understand how they work, we need to look closer on platelet aggregation. So here you have the process of platelet aggregation. We probably spoke about this already with Johannes, but now from a pharmacology point of view, what is happening? We have a tissue injury here, and we have components of the tissue exposed to blood cells that are usually not exposed to, because the endothelial layer here is disrupted. And for example, they get in contact with collagen, which is a strong inducer of platelets. So we have a non-activated platelet coming in here, and then it exposed to collagen, and that will start the activation process. And during this process, the platelet itself starts synthesizing various components that further activate the platelet. And two important ones are thromboxane and ADP. So we will both get back to both of them here, because inhibition of this platelet aggregation process goes through inhibition of the action of thromboxane and ADP, so to prevent further activation. What is usually happening if this is not prevented is that thromboxane, ADP act on platelets. Platelets have receptors for these two molecules. And then you have this formation of the extensions that I showed you on the electron microscopy picture. And then the fibrinogen receptors here are activated, and the fibrinogen bridges can form and then induce the process of platelet aggregation. What you can also see on this picture, we get back to that later, is another compound here, prostacyclin. Perhaps you have heard about that already. This is a molecule synthesized by endothelial cells, and this actually prevents platelet aggregation. So thromboxane, prostacyclin are counterplayers. Thromboxane promotes aggregation, prostacyclin inhibits aggregation. And we will get back to that. So as I said, interference is with prevention of platelet activation by thromboxane and ADP. And in case of thromboxane, this is done through inhibition of synthesis of thromboxane. So in general, when you want to inhibit the action of a molecule, you usually have two choices. Either you inhibit synthesis, then less of the compound is around, or you block the receptor for the compound. And that we will see for ADP. But for thromboxane, it's inhibition of synthesis, and we will look into this more closely. This is another picture illustrating the same thing, but more focus on what is happening with the platelets. So here you have the non-activated platelets with different receptors. Here you see the activated platelet with these extensions and with the fibrinogen bridges here formed during the aggregation process. And you see the molecules again that we spoke about before. We have collagen that activates platelets, and then we have thromboxane and ADP that further activate the platelet. Thrombin we will not talk about. And as I said, with regard to thromboxane, what we do with the antithrombotic drugs is inhibition of synthesis of thromboxane. So how is this done? For that, we need to look at how thromboxane is synthesized. And thromboxane is actually a specific type of prostaglandin. I know that you probably haven't heard about prostaglandin and synthesis before. And these are the conventional prostaglandins. I will not talk about them further. But you need to know a little bit about this chain of synthesis here leading to thromboxane and prostaglandins, and actually also prostacyclin, the counterplayer here. And the key in this metabolic chain, so the way of synthesis is this enzyme here. This is cyclooxygenase. Here you have the full name of the abbreviation, cyclooxygenase. And this enzyme cleaves arachidonic acid. Arachidonic acid is derived from phospholipids, and cyclooxygenase cleaves this arachidonic acid. Then there are some precursors that you do not have to know. And anyway, the cyclooxygenase cleavage leads to the various prostaglandins and also thromboxane. So the way to inhibit the synthesis of thromboxane is to block the enzyme cyclooxygenase. And you know one, it's a very famous one, a cyclooxygenase inhibitor, and that is actually acetylsalicylic acid. You know it probably more as the painkiller, Manyl or Codimanyl. So the main active component in that drug is acetylsalicylic acid, and that acts by inhibition of cyclooxygenase. As a painkiller, it does the job by inhibiting prostaglandin synthesis, because prostaglandins promote pain. But what we are interested in today is that this inhibition of COX also inhibits thromboxane synthesis, so the molecule that activates platelets. And for that, you have actually a specific type of acetylsalicylic acid drugs. See it here, Manyl, it already says what it's used for: prevention of blood clots in coronary arteries, or arteries of the heart. And what you can also see here is the dose. This is one of the very rare occasions when I'm talking about doses. But in this case, as you will see, it's important because this is a very low dose. You may know that when you buy Codimanyl for pain treatment, you have 500 milligrams of acetylsalicylic acid, but in this case, it's just 75, so almost 1/10 only. And I will tell you in the following slides why that is, why it's such a low dose. That's a very important aspect of the whole story here. But before we get there, a little look at how acetylsalicylic acid works, how it inhibits cyclooxygenase or COX. And what you also need to know is that there are actually various subtypes of this enzyme of COX. We have a COX-1 and 2, and there are more, but we are only interested in COX-1 and 2. And acetylsalicylic acid in principle inhibits both. And they are also quite similar. They're illustrated here. This cloudy structure should indicate a three-dimensional structure of the enzyme COX. And this enzyme, as all enzymes, have a binding pocket. So it's a pocket here where usually the natural substrate, arachidonic acid, can bind to the catalytic site to be cleaved, and then the cleavage product will leave the pocket. Again, what the drug now does is that it blocks the pocket for entry and binding of arachidonic acid. And actually, in the case of acetylsalicylic acid, what is important is that the whole molecule, acetylsalicylic acid, gets into the binding pocket, but then the acetyl group in this molecule is cleaved from the remaining molecule, and the acetyl group actually has a specific binding site here, this serine residue, and there it binds covalently in an irreversible way. So that means that this acetyl group will remain in the binding pocket and block the binding pocket as long as this molecule is existing. Whereas other drugs, they go in, block the binding pocket, and go out again. But the acetyl group has this irreversible binding here, and that is one reason why acetylsalicylic acid is used for as antiplatelet drug and not any other painkillers like Ipren. Ipren works similar, but it does not have this irreversible inhibition. Unfortunately, since the lecture has been cut to 45 minutes, I cannot explain to you in more detail why this makes a difference. But I will tell you another reason why with acetylsalicylic acid you get a very good inhibition of platelet aggregation, whereas other COX inhibitors don't do the job. And also explanation for the low dose. And to talk about that, we need to get back to this here, something I mentioned before, and that is that with that cyclooxygenase catalyzes the synthesis of thromboxane, but also of the counterplayer here, prostacyclin. So you may ask now, okay, if I inhibit cyclooxygenase with my acetylsalicylic acid, why do I get inhibition of platelet aggregation? Why do I get inhibition of thromboxane synthesis and not prostacyclin synthesis? Because if I inhibit both, then the kind of balance between the two would remain just on a lower level. But we get actually a change in the balance here. The thromboxane inhibition is somehow stronger than the prostacyclin effect. And I will tell you why that is. So again, this is just a reminder, we have these two compounds, thromboxane promoting platelet activation and aggregation, and prostacyclin is the counterplayer that prevents aggregation. And if we look here now on which cells and which COX enzymes are responsible for synthesis of thromboxane and of prostacyclin, then we see that there are two differences that are important. So what we have here is endothelial cells, and I told you that the endothelial cells produce prostacyclin. It's a little small, but I hope you can see it here. And what I also told you, we have the thrombocytes, the platelets here, and they are responsible for synthesis of thromboxane. So we already have a different cell type responsible for the synthesis. The second important difference are the types of COX enzymes responsible. So what you see here is that thromboxane synthesis only goes through COX-1, whereas synthesis of prostacyclin goes through COX-1 and COX-2. So now, when you think about what kind of COX inhibition do I want if I want to inhibit thromboxane synthesis, but not so much prostacyclin synthesis, then I think the logical answer is I need a COX-1 inhibitor that leaves COX-2 active, that only inhibits COX-1, because then I have inhibition of thromboxane synthesis, but prostacyclin would still be synthesized by COX-2, and that's what we want, because prostacyclin is also inhibiting platelet aggregation. And of course, what we also want is inhibition of the synthesis of thromboxane, which promotes platelet aggregation. So we want a COX-1 inhibitor. And there is nothing like a pure COX-1 inhibitor, but at a very low dose, acetylsalicylic acid is a much stronger inhibitor of COX-1 than COX-2. And that's only true for the very low dose. And that is why for platelet inhibition of platelet aggregation, you use manyl acetylsalicylic acid in such a low dose, what I showed you before, the 75 milligram or 100. If you would use the pill that you use as a painkiller, the 500 milligram, then you get equally strong COX-1 and COX-2 inhibition, and then the dominance of the effect on thromboxane synthesis would be gone. Okay, so if we use acetylsalicylic acid for the antiplatelet effect, we use it in a low dose. We inhibit, okay, COX-1 and 2, but we get a stronger COX-1 than COX-2 inhibition. It's mainly COX-1 in the low dose, and as treatment effect, you get inhibition of thromboxane synthesis, and prostacyclin synthesis stays intact. And by that, in both ways, you get inhibition of platelet aggregation. So I hope I could explain this properly, because it's important. If not, then write me an email or we can discuss it after the lecture. I can stay on here a few minutes. At least I don't see anything in the chat. All right, good. So hiatamanyl, the specific acetylsalicylic acid, low dose for inhibition of platelet aggregation. For the reasons I just explained, only the low dose is effective as antiplatelet. For analgesia, so pain treatment or fever reduction, we use higher dose, about usually 500 to 1000 milligram. Antiphlogistic is anti-inflammatory, and then toxic effects occur already at a relatively low dose compared to the therapeutic dose. But this is something you don't have to care about. That's more for another lecture. But anyway, be aware of this paradox that I don't think you find it anywhere else in medicine, that the lower dose is more effective for the effect we want. So when increasing the dose of acetylsalicylic acid, the inhibitory effect on platelet aggregation will become weaker. I hope I could explain this to you in the previous slides. All right. Acetylsalicylic acid also has side effects. This is also very important. Oh, why is this arrow here? Because here, we have the drug. So obviously, every time you use an antithrombotic, every time you use a drug that interferes with clot formation, of course, you have the same time a bleeding risk. That's a bit individual, depends on the patient. It also depends on the dose, of course, but there's always more or less a risk of spontaneous or severe bleedings. And this is actually so significant that there's a very strong discussion currently whether acetylsalicylic acid should still be used in patients for prevention of clots, especially patients that never had a heart attack or stroke before. Because, you reduce the risk of myocardial infarction, but at the same time, you increase the risk that these people will have a strong and severe and life-threatening bleeding. Another very common side effect is gastric ulcers, so erosions, ulcers of the stomach. And there are actually studies saying that each and every patient who takes acetylsalicylic acid, manyl, has some kind of at least microbleeding. Usually they don't feel it, you wouldn't feel it, but the stomach is always more or less a little bit affected. Another side effect is asthma, that's through the prostaglandins. I cannot explain it in detail. And another side effect in pregnant women would be inhibition of labor and prolonged birth, because prostaglandins are involved also in the development of labors. Now I see something in the chat. When you suspect myocardial infarction, why do you give immediately 300 milligram acetylsalicylic acid? Actually, I'm not aware of these 300 milligram, but I'm not an emergencies doctor, so I cannot really answer this. This question. And I think that I would suspect that an emergency doctor would give rather heparin, that we will discuss later, or a drug that can really resolve blood clots. And these drugs, the thrombolytic drugs, we are not discussing at all because of time. So sorry that I cannot answer this in any more detail. All right, so that was acetylsalicylic acid. That's a very important topic because it's given to so many patients, and that's why I think you should really know about this and also the related side effects. Okay, I told you that we have another compound here that can activate platelets, thrombocytes, and this is ADP. And in this case here, we have receptor blockade, not synthesis, inhibition of synthesis as for thromboxane, but now we have receptor blockade. And the number one drug of this group is clopidogrel. So clopidogrel is antagonist for the receptor of ADP, and this receptor is called P2Y12 receptor. So we have clopidogrel here. It's actually an irreversible antagonist of this receptor, so it doesn't not detach from the receptor, it keeps on binding. And there's a second drug in this class, which is called ticagrelor, and this is an allosteric and non-competitive antagonist, but at the same receptor. So it blocks the ADP receptor in an allosteric way. Indications for these drugs are myocardial infarction, prevention of stroke, and also stent implantation. Stent are these metal meshes that are inserted into coronary arteries in case somebody has a blood clot, to keep them open and to dilate the coronary arteries. And since this is metal, an artificial material, these patients need a very strong antithrombotic treatment, and for that they get clopidogrel, usually often in combination with acetylsalicylic acid, because the combination is even better than any of these drugs alone. Okay, so what I want you to know is really the mechanism of action of inhibition of thromboxane synthesis by ASS, and also the mechanism of action of clopidogrel, which is an ADP P2Y12 receptor antagonist. Nothing else, no other details. Okay, and then we have a final drug class of antiplatelet drugs, and these drugs bind to the receptor that is responsible for the fibrinogen bridges here. This receptor is called glycoprotein 2B3A receptor. You see it here, non-activated, here it's activated, and then it can bind fibrinogen and build these fibrinogen bridges for platelet aggregation. And this is actually all I want you to know about this class of drugs. I think it's a nice mechanism of action. Quite easy to remember, but you do not have to know any names, nothing. They are only used in very specific clinical situations. They cannot be taken as a pill, they need to be injected. So specific drugs, but nice logical mechanism of action, which you should know. Okay, so, I had to click through this because I didn't remove the answer. Okay, a little question for you. I hope you can see this. Some questions about acetylsalicylic acid. So what is correct? Is it an antagonist for the P2Y12 receptor? Or is this correct that when used at very low doses, it has no side effects? Or is it that at low dose, it inhibits COX-1 more strongly than COX-2? Or is it that acetylsalicylic acid inhibits formation of the fibrin net? Or is this all not correct? Okay. Yeah, with the responses, vast majority is saying at low dose, it inhibits COX-1 more strongly than COX-2. That's absolutely correct. And that was the key, right? That we get inhibition of thromboxane and not prostacyclin. Exactly. Answer here would be clopidogrel. At a low dose, it still has side effects. We discussed them: bleeding, gastric ulcers, inhibition of labor, and what was the fourth that I had on my slide? Asthma attacks, right? And this year, inhibition of fibrin nets, that's actually something we will discuss now in the following, because that are the, and now I'm stuck again here, sorry. I have to do this. Okay, yeah, that's the anticoagulant drugs that inhibit formation of the fibrin net, as we discussed before. Okay, what I had to click through quickly because the answer was there was you will see in between a slide where I have grouped antithrombotics on one side and anticoagulants on the other side to make it easier for you to really distinguish these two groups of drugs. But you will see that again in the following without any answers of my questions. All right, so for understanding the anticoagulants, we need to look at the clotting cascade, which is responsible for the synthesis of fibrin, which we need for the fibrin net, obviously. And I think you discussed this with Johannes. Luckily, as a pharmacology, I don't have to care about all these different factors here, but as a pharmacology, I'm only interested in factor 10A and in thrombin or factor 2, because all the drugs that interfere with the clotting cascade, all the drugs that inhibit the clotting cascade to have less fibrin synthesis and less clot formation, so through coagulation, all the drugs interfere either with 10A or with thrombin or with both. And that's the key. If you have a drug interfering with one of the two clotting factors, you will get full inhibition, or at least therapeutically sufficient inhibition of fibrin formation. So first drug we are going to discuss is heparin. I'm sure that many of you have heard about heparin because it's very frequently used specifically or mostly for prevention of blood clotting. And the classical situation is patient undergoing surgery, especially surgery of big joints like the knee joint or hip. There you have a very high risk of clot formation, and these patients get heparin for prevention of clot formation. But also others after bigger surgery, especially if they are immobilized for several days, then they get heparin for inhibition of clot formation. So what is heparin? Heparin is a high molecular weight mucopolysaccharide. You see the chemical structure here, and it's like various of these chains added together, resulting in molecules of same structure or same like components, but of very different size, between 4,000 and 40,000 Daltons. So it's really a large variety. And until today, the heparin, because it's so large, it's basically impossible to synthesize it in a chemical process. But heparin is still isolated from the gut of pigs and the lung of cows. And then, of course, purified, and the actual heparin molecules isolated, purified, cleaned, and so on, and then administered to patients. But this is a source of what is the word? So that you have components in the actual drug that is applied, which should not be there, and that was the case a few years ago with a lot of side effects. But okay, that's another topic. So how does it work? That's more important. How does heparin work? Heparin itself actually has no action on clotting factors, but it needs antithrombin 3 for its action. So heparin is actually acting on antithrombin 3, and you probably heard about it with Johannes, that antithrombin 3 is a natural molecule that we have in our bodies that is able to inhibit clotting factors. But the inhibition by antithrombin 3, or from now on I say AT3, is not very strong. So only when it's in addition activated by heparin, AT3, it will become a very strong inhibitor of clotting factors. And you already see here which clotting factors are inhibited by AT3. It's 10A and 2A. So 10A and thrombin, the two key ones that I mentioned before, that lead to a sufficient or therapeutically effective inhibition of fibrin formation. So here's written what I just explained. What heparin does is acceleration of inactivation of clotting factors by AT3. And another thing that is important to know is that there are two types of heparin. On the one hand, you have unfractionated heparin. That means you have heparin molecules of all sizes, everything between 4,000 and 40,000 Daltons. But there are also heparins on the market which are so-called fractionated or low molecular weight heparin. Let's see this here, low molecular weight heparin. And this is product that is just made from the shorter heparin molecules. And this has advantages. There are less side effects, and it has a longer half-time. But the other type of heparin is also still around simply because it's cheaper. I see something in the chat. Do we have heparin naturally in the body? That's a very good question. I think the answer is yes, because other mammals have it also. And I tried to look it up. It's not easy to find information, but I think the answer is yes, but probably not in high amounts, so that when you give it as a drug in a high amount, you still get an effect that is much stronger than what the body can do itself. Okay, so we have unfractionated including long molecules, as you see here, and we have fractionated, which is this low molecular weight, as you can see here. And for inhibition of 10A, the shorter molecules are sufficient that only bind to 83, but not to 10A. But for inhibition of 2A, you need larger molecules of heparin that bind to 83 and 2A to then give an inhibition of 2A. But in the end, who cares, so to say, because if we inhibit 10A, we get the full therapeutic effect. So unfractionated heparins bind, inhibit 10A and thrombin, and the fractionated low molecular weight only 10A, but the therapeutic effect is basically the same. Two examples. I told you that it's mainly used for prevention of blood clotting after surgery. For that, it's injected subcutaneously, usually into the subcutaneous fat of the abdomen, of the belly. But heparin is also used, and I also mentioned that shortly before, in the acute situation, like in myocardial infarction, if somebody has an acute myocardial infarction or a deep vein thrombosis, it's given as a treatment to dissolve the clot or to prevent that the clot will even more grow. And then it's given in high dose with these machines that release heparin. It's in the syringe here in a very controlled way, because of course, if you give it in a high dose, you really have a higher risk of bleedings. And so it has to be done very carefully. Okay, so here you have this slide. What I said, the antiplatelet drugs, we discussed them. You have them here, and the anticoagulants, and the number one we discussed is heparin. The big disadvantage of heparin is that it needs to be injected. These mucopolysaccharide molecules, they are not stable in the stomach. They would be degraded if this is taken as a pill, so they have to be injected, as you saw before, subcutaneously, for example. That's a disadvantage, of course. That means that people can hardly use this at home. And that's why we also have orally active anticoagulant drugs. And the still most commonly used one, like the historical class of drugs, are the so-called vitamin K antagonists. And they inhibit several of these clotting factors, but importantly, again, 10A and 2, or thrombin. And what do they do? So the so-called vitamin K antagonist, which is not a good term, but that's how they are called, they prevent the formation of clotting factors that depend on vitamin K. And vitamin K is a carboxyl group donor. And what is happening in the liver, where these clotting factors are synthesized, is that you have an enzyme around here which is called vitamin K reductase, and the vitamin K reductase is there to kind of make this use vitamin K or add another carboxyl group to the vitamin K again, so that it can go into this cycle of clotting factor synthesis again. So vitamin K reductase is needed for the activity of vitamin K, and the drugs that are used as anticoagulants are actually vitamin K reductase inhibitors. So it's again an enzyme inhibition. In this case, you call these drugs inhibitors and not antagonists. That's why the term is not great. Vitamin K antagonist is not a good term. The correct term would be vitamin K reductase inhibitors, and by that you inhibit formation of clotting factors. So we only have 2 minutes left. Quick story. You know this guy here from the movie Ratatouille. And in this movie, he has a role, and that is he is a food taster of his family of rats, which is something that is also happening in nature. Later, he becomes a famous chef, but he starts as a food taster. And actually, in nature, rats always have food tasters, but not to try whether food is tasting nice, but to try whether anything is toxic. So if you want to develop a rat poison, you need a substance that only acts with a massive delay so that the taster will survive eating this poison for several hours, and the others will start eating it as well, so that then you can kill the rats. So delayed onset of action is very important. And why I'm telling you this? I'm telling you this because warfarin was originally developed as a rat poison. The rats die from inner bleedings in the end. So this little story perhaps helps you to remember these drugs have a delayed onset of action. Warfarin is a vitamin K antagonist. Oh, yeah. So we have warfarin here. Orally active, this is good. Delayed onset of action causes a lot of troubles because the main problem is that the dosing and the monitoring of the dose is very difficult, because when you change the dose for a patient or you start treatment in a patient, you will see the result. So you will see how strong did I inhibit coagulation only with a delay of about 2 days. So this is really a long delay, and that's why it's very difficult to adjust the dose according to the individual patient. And this is reflected in what is written here. I will stop soon, no worries. And another problem is interaction with a lot of other drugs and interaction also with food ingredients. And that's why people thought, okay, we need something else. That is the last thing I will tell you, and it's the last learning objective. The new class of drugs are so-called direct thrombin inhibitors. So last learning objectives here. Direct thrombin inhibitors, and these drugs, and the one that is orally active is dabigatran. They inhibit thrombin directly. And what does it mean? Why directly? So I told you before that heparin is a kind of indirect inhibitor because it inhibits antithrombin 3, and through that inhibition indirectly inhibits thrombin. Whereas these new drugs, dabigatran, they bind to thrombin directly and inhibit thrombin without the help of AT3. So direct thrombin inhibitors, dabigatran, new class of drugs with a much faster onset of action, so easier to dose, no food interactions, very few drug interactions, so much easier for the treatment of patients. Okay, so I stop sharing now. We don't have time for the last question that I had for you in Paul everywhere. Or if you want to stay on, we can do it. But for now, yeah, everybody who wants to go can go, of course. If there are any questions, I'm watching the chat, or you can also talk to me. Okay, there's something. How about Xarelto? That must be a trading name. So I don't know what is in Xarelto. Do you know what is the active ingredient, the generic name? Rivaroxaban. Yeah, that's a direct 10A inhibitor, but it's not in the learning objectives. Is the high molecular weight of heparin why it can't be given orally? No, it's not the molecular weight. It is the molecule is unstable in the acidic environment of the stomach. Acidic, and yeah, there are also all kind of enzymes around. That's why. You can take the rest of the slides if you want. Thanks. There are basically no other slides. I mentioned rivaroxaban, that's what somebody asked for. So let's see. But there's another question, that if you want to see another question, which of the following drugs prevents formation of the fibrin is given to the patient as a pill? See whether anybody is still, oops, sorry for this. Okay. If you want to play here, you can still do this. No? Okay, then you have it. You have seen the question, and that's also fine. Okay, Stop sharing. Okay. Thanks for listening. Have a good day and good luck with the exam. Bye-bye.